certified surgical oncologist, Dr. Heather Wright. I have had the pleasure of personally working with her in the operating room for almost 2 years now. Most of the patients we work on together are women with breast cancer. Dr. Wright is here to explain a few of the common procedures. Dr. Wright, now if people get diagnosed with breast cancer, what are some of the procedures that they would be having?
So when a patient is diagnosed with breast cancer, basically we're focusing on, with surgery, the breast and the axilla or under the arm. When we're talking about removing the cancer from the breast, there are two options. One is to have the entire breast removed, and with or without reconstruction. By law, insurance is required to pay for reconstruction after a woman has a mastectomy for breast cancer.
Okay.
The other option is to do what we call a partial mastectomy or lumpectomy.
Okay.
And in that case, what we do is we remove the tumor in the breast. We try to get normal tissue around it to make sure all of it is out. And then it's like having a breast biopsy. We leave the rest of the breast tissue in place.
Okay, and so then let's go over that. The needle localized biopsy, what happens with that?
So if we can't feel the lesion, then we have to have our radiologist kind of show us exactly what to take out. So let's say there are only some calcifications. So a lot of times in non-invasive cancer, it forms these little calcium deposits in the breast, and we can't feel those. So what we do is we have the patient go to radiology ahead of time, and they can put a little wire that goes to that area, and that shows us exactly what to remove.
Okay, perfect. And those that you can actually feel it, and they have what's called a lumpectomy.
Correct.
Okay. So the next thing would be those that say have a family history of breast cancer, or they have fibrocystic breasts and they're very painful, and they get to have a prophylactic mastectomy. How is that different for a mastectomy if you do have breast cancer?
So in that case, we don't generally need to check lymph nodes.
Okay.
So essentially the mastectomy part is exactly the same. And you know, we have a little more leeway. Let's say we're not worried about if we want to offer a woman a nipple sparing mastectomy and they have cancer, for example, we need to make sure that the cancer isn't directly behind the nipple or involving the nipple. Clearly with a prophylactic mastectomy, we don't have those concerns, limitations, things like that. And we don't have to check the lymph nodes because there's no cancer there. Now personally, I like to have a breast MRI at least 6 months prior to doing a prophylactic mastectomy. That way we know there's nothing there that we're concerned about.
Okay, perfect. And those people who do have sentinel node biopsies, is there any precautions that they have to take afterwards?
So with a sentinel lymph node biopsy, we inject a little bit of tracer into the breast. It travels to the lymph nodes under the arm, and we take out those first lymph nodes that drain the breast. So those are the ones most likely to have cancer, if any of them do. With a sentinel lymph node biopsy, typically we're only taking out a few. So maybe 1 or 2, sometimes 3 or 4. It depends on how many take up enough of that tracer. The fewer we take out, the fewer precautions you really need to take with your arm. So we say if we remove up to 4, perhaps you don't really need to avoid the IV sticks and blood pressures in the arm. When we take out more, there's more of a chance that you would have arm swelling, lymphedema, and you could have some complications. So in those cases, sometimes we have them take some extra precautions.
Okay, perfect. And the last thing that we'll talk about is the modified radical mastectomy.
Right, so if we know that a woman has lymph node involvement, we know that she needs an axillary dissection. When we do a mastectomy, so removal of the breast along with an axillary dissection, then that's called a modified radical mastectomy.
Okay, perfect. Well, thank you, Dr. Wright, for all the knowledge that you just shared. That is all we have for today, and thank you for watching the Foob Tube.
Thank you.